our last session is very, very important, and it's really mixed with research and also topics. And I would like to introduce Dr. Ahmed Rubay'i again to start that session and introduce our moderators. Thank you.
Thank you. The reason why I prefer to introduce the moderator is that this year we have two highlights. One is related to the research. We have a good work in research, and all went into a collection, and our colleague, Professor Haider Al-Ubaidi, the head of the research and ethics committee, had a lot of work on selecting, going through the studies and the poster there. So that's one highlight. This is the first time our medical conference includes a segment on research. The second highlight is related to dental work. This is the first conference where we have a dental session. We established a dental committee or dentist committee in the organization. That's why just allow me to welcome the two moderators. The first moderator is Associate Professor Bilal Zaidan. طبعا راح تشوفوا that you can see Dr. Bilal, you think he's still probably just finished his bachelor's degree. He's Associate Professor in Data Science at SP Jain School of Global Management in Sydney, and his work is focused on artificial intelligence decision-making system. He's one of the experts. He and our colleague Aus Al-Jabouri, some of the top experts in AI, although they are very young, and they are experts, and we managed to get them managing the unit for the artificial intelligence in our IAMA and the Academic Association. So I welcome Dr. Bilal. And the second moderator is our colleague Isra Awad. She's a dentist and a second-year PhD candidate transferred from master candidature at the University of Queensland School of Dentistry, and she is investigating oral health access and equity for culturally and linguistically diverse children and family in Queensland. She is one of the participants in the research and the poster. Thank you very much.
We are going to welcome here Professor Haider Al-Ubaidi, the chair of IAMA Research Committee. He's a professor of learning and teaching in medical education in Australia, and he is distinguished medical practitioner, researcher, and educator with extensive experience in academia and the clinical practices. His research focuses on early detection and prevention of type 2 diabetes, particularly the anti-inflammatory, lowering and glucose lowering. Sorry, I'm not familiar with these medical terms. He has published extensively in a peer-reviewed journals and serves as editorial board and as a reviewer for several international medical journals. So welcome, Dr. Haider. Sorry for the introduction. No problem.
Good afternoon, everyone. So the aim of this session is to acknowledge and promote the scientific achievements of our Iraqi doctors as well as our medical and research students. We wanted to acknowledge this and promote their achievements both nationally and internationally. So what we did over the past few weeks, we have invited the researchers through the IAMA portals to submit their recent publications as well as their posters, presentations to be included in our research award. And what we did next is we've developed an assessment framework that enable us to go through all the publications and provided some sort of a rubric criteria to enable us to compare between the published work. So the main rubrics focus on the scientific quality and the methods used, the originality of the studies and their innovation, result interpretation, relevance, and their clinical and scientific impact, as well as the clarity and the scholarly communications. As you can see here on the screen, we've got certain percentage for each one of these criteria, and then we transfer this into a scoring rubrics to enable us to have that comparative. So for the research paper submission, we've got a total of 12 papers submitted so far. And this is considered to be okay within taking into consideration that we've promoted for this session a few weeks prior to the start of the conference. So hopefully in future years when we've got more time or more notice, we will receive much more than this number. Majority of the papers were focused on clinical research. However, we've got some papers focused on the applied research, cross-sectional studies, systematic reviews, as well as conceptual framework. The next slides will be announced for the winner recipients. During this session, we will announce who got what, but the prize will be awarded to the winners during the gala dinner. So stay tuned during the gala dinner for the prizes. And I'm pleased to announce that Ghufran Al-Hassani from Western Sydney University has got the highest impact for her paper. Where are you, Ghufran? Just raise your hand. Say hi to Ghufran. So her paper entitled "The Interhemispheric Inhibition Between the Primary Motor Cortices is Not Altered in Individuals with Chronic Lateral Epicondylgia." The total score for this paper comes to a total of 88. There are other two papers which comes very close, but Ghufran's paper scored the highest one. And the key strength for this paper outlined briefly here. It's the rigorous study design, the advanced neurophysiological methodology, the robust, solid statistical analysis, publication in a peer review and well-recognized journal, as well as clear disciplines interpretation of the findings. Congratulations, Ghufran. Wonderful. As for the poster submission, we received a total of 18 posters. And also the majority of these posters focus on clinical research. Applied sciences comes next, as well as we've got a couple of papers focused on cross-sectional studies, as well as conceptual framework. And it's also my pleasure to announce the winner for the poster submission is Rania Al-Atiya from University of New South Wales. Where are you, Rania? Congratulations. Her poster entitled "Activation of a Human CD4, CD25, CD127 TREG with alloantigen and ribosomal interleukin 2 induces interferon gamma receptor." The total score is 89, and its key strength, its high relevance to the immunotherapy and transplantation sciences, strong translational potential to autoimmune disease management, advanced understandings of the regulatory T cells activation mechanisms, as well as showing that clear linkage between experimental findings and clinical applications. We've got a sample of all the posters distributed outside in the foyer. If you haven't had the chance to look at them, please save 5 to 10 minutes of your time following these sessions to have a look on them and meet with the presenters. Lastly, the IAMA Ethics and Research Committee acknowledged the high quality submission across the diverse research domains. There were a strong presentation of the clinically relevant research, and as we said, the marking rubrics has focused on multiple aspects. Key aspects is the methodological excellence, the innovation, and the translational impact. And finally, this is just wanted to acknowledge Dr. Ahmed Al-Rubai and Dr. Ali Fayyad for their efforts in helping us in reviewing this research work. We look forward to more of your contribution in the future conferences. Thank you. Yes, the prizes will be at the gala dinner in the next few hours.
Mr. Haider, you also get the prize for the quickest presenter.
Next one is going to be presentation, right? Yep. The last and the only dentistry presentation is for Dr. Rima Hadi. She's a plastic and cosmetic surgeon. She works in Swan Clinic and Karina Private Hospital. She's also working in medical council and medical. Can you come here?
Thank you. Okay, thank you so much everyone for being here, for surviving the day. Thank you to the organizers. I know organizing this is not easy. It's been actually a lovely day. Your faces are all beautiful. And I hope I see you all, but not in the medical council. So why am I here? So I finished plastic surgery training 10 years ago. I did general surgical training and I did some vascular. And after 10 years of private practice, I started doing some work with the medical council, the tribunal, and I enrolled in a law degree because I'm bored and it's a midlife crisis. Thank you to my poor husband for putting up with me. So what I want to do today is talk to you, first of all, how do you identify problem patients? How do you treat patients carefully? How do you prevent complications, both physical and mental? And how do you deal with complaints? My colleague, Dr. Ola, will talk more about screening, but essentially, if you have the privilege of screening for the patients beforehand, the GP referrals are amazing. Sometimes, however, they slip through and we're all stuck with them. So this is about how do you deal with them once it's happened. The screening tools are multiple if you get the chance to do so. I think anybody who wants any procedure should go through this. I don't think it should just be us. APRA changed the rules 3 years ago. I'm so happy. Now I can say, I'm really sorry, I can't operate on you. You need to see a psychologist or psychiatrist. I thought there was only borderline. However, it turns out you can have lots of personalities. All of them are very multiple colors, and all of them make it very difficult for us to treat. They challenge us on multiple ways. It makes it very difficult to treat them. They don't cooperate, they don't listen to instructions, and it feels like we're not on the same team. I did a course with the Blue Knot Foundation, actually dragged my staff and my nurses there. It was really helpful. Basically, it taught us to treat everybody as if they've been through trauma. And I'm not talking about general surgical bleeding trauma, I'm talking about psychological trauma. So essentially, in a nutshell, skill sets that are not naturally innate to surgeons, which is treat everybody kindly, be gentle with everybody, explain what's about to happen, give them a chance to ask questions, make sure the paperwork's done properly. Again, College of Surgeons taught us how to operate, did not teach us how to treat patients from a gentle perspective. And I think moving forward, this generation, I look at my kids, I look at my sister-in-law, this is what they expect. It's not just about the medical, you got it right medically, but it's about the other part of it, which I guess is customer service, you could call it. It's about looking after it. So, and everybody, all of us, if you're seeing patients, we're all going to be in contact with this. The other thing I think is really interesting about this is I thought there was only flight and fright, but now we know that there's also freeze. Freeze is a problem because I used to do procedures under local. If the patient freezes and they're going through trauma, how do I know? Because they're not saying anything. So gradually I've changed more and more to doing things under general or sedation. If I do things under local, and my advice to everybody who does, including our colleagues, the radiologists, you really need to be careful. Have someone with them. Are you okay? Are you okay? Can I proceed? Otherwise, you know, you're in danger of, I'm traumatized by the procedure mentally, and that has kind of serious medical legal implications later. Even if you've given consent, you have to keep checking on them. Patients who have been through mental health trauma, and I guess in context, a lot of us have been through war. War is trauma. Immigration is trauma. Loss of family, loss of income, loss of resources, that's all trauma. So all of our patients from our community innately probably have been traumatized. And I think we have to be especially kind to them, especially gentle to them. Whenever I see a patient of a similar background, I always think, oh my gosh, yeah, I know what you've been through in one way or another. So a lot of those patients, sometimes everything's going well, they react in anger, avoidance, they don't answer the phone. How many times do I have to call you to check on you? Dissociate, they self-harm, drugs and alcohol. And you think our community doesn't have drugs and alcohol? There's a lot of drugs, both prescribed and non-prescribed. So before doing anything, embarking on any treatment, I always try and understand what the patient wants. I try and build trust and rapport, God knows. We try to have shared decision-making. We try and manage unrealistic expectations. And I always try and see them more if I think that they didn't understand. I'm not going to go through all this. Other than to say, I now have a diagram, I draw on the diagram exactly what happens, and I make the patient sign it, and I give them a copy. Because I think the biggest danger is when people are in that mental health phase, they don't listen, they don't hear what we say. At least I can go back, remember we said this? Our consent form used to be a piece of paper with one line, I would consent to this. Now it's war and peace. This could happen, this could happen. They have to sign every single page and return it and keep a copy. And it's sad that it's like this, but I think this is the world we live in. Again, I'm going to skip through this, other than to say, I think our community is overrepresented with the medical council because I think we are gutsy people who do things that are slightly out of the square box. I think consent's really important. Make sure that you have the paperwork that matches what you're going to do. Make sure the patient's carefully consented. If a patient is not happy, I always get the nurses on board. I try and have a family conference. We talk about what happened, try and understand what occurred. And sometimes there is no complication. It's a mental health issue. But I think it's important also to get the backing of your colleagues and know when to refer. So apparently we're supposed to have a complaints policy in the clinic. This is something new to me. So explain what happened, document it, ask them to send you the complaint. If they complain to you, it's less likely they're going to complain to someone else. Have someone in your clinic, like a practice manager or a nurse, to deal with it, because it sounds like you escalated it. If you deal with it, then nobody else has to deal with it. How do patients adversely react? They can give you a bad review on Google, RealSelf, or RateMD. It's very painful. It's very, very painful because it's often one-sided. If you answer back, don't take it personally. Ideally, have a generic reply that's pre-written. If you know who it is, you can email them and take the discussion off the forum. Don't breach the patient privacy, because so far nothing's happened. If you breach the patient privacy, it's misconduct or unsatisfactory professional conduct. You can go down the defamation route, but I don't think it's really ever worked. If you end up with, God forbid, an APRA HCCC complaint, remember, most complaints don't proceed anywhere. Really, APRA knows that this is just a method of the patient escalating or bringing up an issue. If it does, get your medical defense to help you write a response. Sometimes the HCCC and the medical board will refer to the medical board or medical council, which is how I get involved. Worst case scenario, then it goes to the tribunal. Essentially, the advice is be honest. They call it candor in legal terms. Don't obstruct the investigation. That itself is professional misconduct. If you get a medical legal letter, so separate from that complaint, sometimes, again, it's often fact-finding. If you have good notes, you respond back. Lawyers are less likely to be interested. get your medical defense to check it before you reply. As I mentioned, just make sure you have thorough consent. And usually the medical defense will just pay the patient to go away because they don't want to avoid the cost of litigation, even if you've done nothing wrong. So remember, 99% of patients are happy. It's the 1%, I guess, that end up, I see them later. If you need any advice or support, I'm happy to help just from a very little legal background that I have. But remember, like, everyone's doing a really good job, everyone's trying really hard. It's not you, it's them. But at the same time, try and put in things in your practice that help prevent these problems. Thank you very much.
To some question if they are available. Anyone has a question? Okay, that's good. Thank you everyone for your patience. It's a pleasure to close tonight with my favorite topic, dentistry, presented by Dr. Ola Zaidan. Dr. Ola brings experience across public and the private sector in New South Wales, holds a doctorate in dental surgery and a graduate certificate in clinical dentistry with honors from University of Melbourne, and is currently completing a diploma in orthodontics. Welcome, Dr. Ola.
Thank you, everyone. Last but not least, it's our final lecture for today. So today I'll speak about psychological screening in cosmetic dentistry. So it's a new guidelines from APRA from last year, September. APRA now has guidelines about all dentists who are practicing, who are solely working with patients who are seeking cosmetic dentistry. So this applies only for cosmetic works. It's not applying for dentists who are restoring function. The presentation outlines, we'll talk about some introduction, APRA guidelines briefly, ideal cosmetic patients, treatment expectations, and we're going to talk briefly about body dysmorphic disorder, risks of treating patients with poor mental health, warning signs, assessing patient suitability, screening questionnaires, how to refer, how to approach the patients, and preparing patients for satisfaction. Many cosmetic complaints and negligence claims are not related to technical errors, but poor patient selections. So most of the time, dentists actually achieve very good results. Patients usually are happy initially, but then they lodge a complaint, and it's not about the outcome, it's more about the poor patient selection. How do you currently assess patient suitability? So how do we know which patients to treat and which we don't? So this is the new APRA guidelines. This is not only about dentistry, it's also about other health practitioners who are going to do any aesthetic treatments that are not surgical. We have to go through the screening. I advise everyone go to APRA's website and go through the pages and read it, because there's a lot there to talk about. APRA guidelines. So these guidelines now apply to all health practitioners performing non-surgical cosmetic procedures. They apply to treatments where the dominant purpose for the patient is to achieve a more desirable appearance. Now, we can say the treatment was mainly for function, but if the patient actually requested the treatment to be mainly cosmetics, then we can't argue that's functional, because that's the main purpose for the treatments. So it's for the procedures which changes the appearance, color, texture, or position. And the dominant purpose of the treatment is what the person perceives as a more desirable appearance. As an example, veneers, even teeth whitening because we are changing color, any cosmetic injectables if dentists doing that. Also probably braces if we are doing minor adjustments, mainly for cosmetic work, then that can be also included. If the primary purpose of the treatment is functional, BDD or body dysmorphic disorder evaluation is not required. But if the main purpose is aesthetic, then we have to do the evaluation. Motivation, so we need to ask about motivation, the patient, whether this is intrinsic or extrinsic. If the patient has been pressured by a friend or pressured by an AI image of himself that he has created, or an influencer online, then we have to consider that that's an extrinsic motivation. We need to understand about risk factors. If concerns arise, then we need to refer. We need to refer to either back to the GP or refer to a psychologist or a psychiatric. So the ideal cosmetic patient, we have to look for appropriate motivations, stable mental health, realistic expectations. So we need to listen to the patients talking about what's the expectations, can understand the risks, and if risks happen, patients can tolerate it. Balanced self-perception, able to afford the procedure, and if concerns arise, again, we need to refer. We'll talk about treatment expectations. So 2 ways to be happy, we always have to know that we either improve the reality or reduce the expectations. So if patient's expectations is high, we need to bring the expectations down a little bit and make it more realistic. Body dysmorphic disorder. So APRA strictly talked a lot about body dysmorphic disorder because this is the most common type of mental health problems that we get into the medical or dental departments. There's a lot of other mental health conditions we're going to briefly talk about, but we're going to focus more about BDD. So APRA stressed specifically on BDD because it's the most consistently documented risk factor for poor cosmetic treatment outcomes. BDD involves fixation on one or more body parts and a distorted perception of appearance. So you'll often find patients come in the clinic and talk about their appearance with a lot of exaggeration. For example, they avoid looking on mirrors, or they say, oh, I've got disgusting teeth. You show them x-rays or pictures, and they completely push away and don't want to look at it. And they talk too much about their appearance. And when you look at them, you don't see that. You see them like normal people, but they just exaggerate a response. Many of BDD patients will not be satisfied with the cosmetic treatment outcome, regardless how good the treatment is. So the indicators can be language, for example, a strong negative language like disgusting. I don't want to look at my teeth. I don't want to look in the mirror. I've been avoiding to go out for the last 6 months. I'm unhappy with my look. You are the only person who's going to help me. Once I get this treatment, I'm sure I can buy this house, or I can find this job, or maybe I can get married eventually. Behaviors, for example, the mirror thing, avoids or too obsessed about looking in the mirror as well. Photo library. Sometimes you get patients, they have a photo library on their phone with all AI images of themselves or filtered images of themselves, and they want to look like that. Well-researched, so they know everything about what they want, and they tell you what they want to do, not ask you. And urgency of treatments. So they are really have that urgency. They want the treatment done now because they have something coming up. And emotions. So emotions, they often come like very tearful. They sit on the chair, they cry, they are very anxious, they're very defensive with the language, and desperate to have the procedure done as soon as possible. Risks of treating patients with poor mental health. So this is general, why it's too risky to treat those patients. Reduced capability to cope if something goes wrong. So if something goes wrong, which can go wrong, those type of patients usually don't cope very well with the complications. They can complain, and they have unrealistic expectations as well. So they have very high expectations of the treatments. Although you explain to them everything, and they initially might agree, but then when the treatment is done and it's good and the aesthetic is very good, the patient is usually not happy. Dissatisfaction due to external factors. Heightened pain perception, so they often be in pain even if you haven't touched them yet. They will just push away and say, ouch, that hurts. I don't like this, I don't like the suction, I don't like the nurse touching my face, I don't like that. They do complain a lot about that. And increased likelihood of complaints or conflict. Signs to look out for, or red flags. So flat or anxious patients, or anxious mood. Repetitive questioning. So a patient asks the same question in a different way all the time because they are seeking guarantees and reassurance. Long lists of concerns and physical signs. So self-harm scars, teeth erosion from eating disorders, that can be also a sign. Assessing patient suitability. So we ask about history, for example, previous cosmetic treatments, dissatisfaction in the past with the procedures, repetitive cosmetic procedures on the same issue. And they often say, oh, I've seen that dentist, I'm not happy with that dentist. And then when you ask more, I'm not happy because I didn't get this and this and this and this. And you think it's a bit unrealistic. That can be also a red flag. Psychological, so it can be motivations, expectations, or even recent stresses. A recent divorce, someone came in, I want Hollywood smile because I just got divorced and I want to take revenge. Social, for example, teasing, bullying, abuse, or social media. I've got nice questionnaires from a clinical psychologist. I thank her so much. Her name is Dr. Tony. She's happy for me to pass on the questionnaires. So she made a brief BDD questionnaires, and there is more like a link we can get on an iPad and then send it to the patient with more detailed questionnaires. So this one covers mainly BDD, but I have one for like generic other psychological or mental health issues. The other one can generate an automatic report, and then we can use that as well. So I'm happy to share it with everyone because I took her permission and she said pass it on to everyone. And it's not only for dentists, so even doctors who perform aesthetic or cosmetic procedures can actually use that. This is all about scoring. This is scoring as well, part of the screening, but I'm happy to pass it on. I put my email address, and anyone who needs it, I'm happy to email it to them. I won't talk in details about it because it's all self-explanatory. Screening questionnaires and why we use the screening questionnaires. It's time efficient. It only takes a few minutes. We can give it to the patient when we give medical history to fill up in the reception. They can fill that as well. It takes only 1 or 2 minutes extra. It requires less expertise than clinical interviews. It is standardized and provide documentation, support clinical decision making, offer a framework for discussing referrals. So we can use it as an excuse for not treating patients. We can tell them, look, you've scored this and this and this. This is why we're not doing the treatment today. It's useful when patient is unaware of their diagnosis as well. So how to refer? We have to use the 4 R's. So we have to relate. We have to feel a bit sorry and sympathy with the patient. We have to acknowledge that the patient's feeling and desire for treatments. We have to tell the patient, for an example, I can tell how difficult this has been for you and how eager you are to have this procedure. Reassure, we have to emphasize your commitment to have the well-being. My main priority is your physical and emotional well-being, and that you are satisfied with the procedure you decide to undergo. And then we refuse. We have to explain how to refuse. We will say, based on the results of our screening and my professional obligations, I'd like to arrange further assessment before we go ahead. And then we refer. So we normalize the referral and direct them to the appropriate professionals. I would like you to have a chat with your GP or psychologist to further explore your motivations and expectations and discuss any additional support that might be helpful to get the results you are looking for. How to increase the chances of patient satisfactions. So before treatments, we have to make sure they are in the right mindset. They are properly informed patients about their emotions, physical and satisfaction. And we have to bring down the expectations and post-operative support. So we need to check on the patients after the procedure. We either do text messages, phone calls, or even a review appointment.
3 minutes.
Thank you.
Yeah. So can we please invite the speakers back for the Q&A session? Thank you so much. It was really a very, very fascinating talk and very important for us all. We always think of the patient step into the room, are they going to step back and put a complaint?
Excellent. It's so fascinating. Thank you to see a surgeon, a senior surgeon, talk about medico-legal issues at the same time. Talking from about myself as a solo surgeon in a very busy clinic, but insufficient admin staff surrounding me. You sensibly spoke about providing the RACS brochure with some handwriting outwriting about the complications, etc., and provide some exit strategy protocols as well to them, and also, of course, the financial consent separately, and also sensibly mentioned that a complaint policy that can come. What's your advice about how can we get all of that sensibly, routinely done in, once again, a busy surgical practice with limited admin staff surrounding you?
Okay, essentially, I have things automated as much as possible. So when they book, we send them an email of what to expect on the day, what to expect when you come, how much is this going to cost, how much you get it back from Medicare if you can. It also includes for us roughly what the price would be. And actually, recovery and things like that. What specialty are you, doctor?
Upper GI surgeon.
Upper GI, okay. Then when they come in, we have paperwork they sign that consents to collection of information, consents to photography. If you don't get consent for photography, it's also an issue. I don't know if it's relevant in your life. We collect data. Then I get them to fill out a screening tool, which is, apart from what Dr. said, sorry, you're here now, also talks about expectations. What do you want? Why do you want it now? Is your family supportive? What support do you have at home? I'm happy to provide you a copy of that sheet because I think it's very useful for your job as well. Then when I see them, we go through a PowerPoint. I ask them consent to examine them. I examine them, I offer the nurse to come into the room, then I draw them a diagram of what they're going to get. Then I say, okay, this is the first consult, come back for a second one. Then I take them to my nurse. The nurse has a checklist to talk about recovery, to talk about financial consent, to talk about the quote. Everything is pre-arranged. She just has to go and she spends 15 minutes. It costs more, I understand, but the pain is much worth it to avoid the pain later. Because now 2 people have spoken, and by nature, the patients trust nurses. They ask them, is she a good doctor? Yes, she's fantastic, because they can see I look after the patients. The same nurse who sees them before surgery is there intraoperatively, is there postoperatively. So she is either a surgical nurse, like a scrub nurse or an anesthetic nurse, and she is with them the whole journey. She calls them afterwards, she sees them post-op. So when the patient says, I'm not happy or I have swelling, she can say, oh, remember we talked about this? So 2 people, I don't know, 2 witnesses against the patient. I know it sounds terrible because they don't remember. We have found that this has prevented a lot of trouble. I'm not going to say that it's trouble-free because I now understand it's the screening. They published in the clinics of plastic surgery a whole, it's quarterly, the whole quarter was on this. And they basically said it's a personality problem. No matter how good your paperwork is, no matter how good you've done it, if the patient has a personality problem, there's pretty much nothing you can do, except that what we have done protects us. The lawyers are less likely going to bother. This is not going to be worth it for them. Look at the great work she or he has done. So I think those things have helped. The nurses, and the key to keeping the nurse is to pay them very well. I pay them extremely well. I make sure that they're looked after. I give them gifts on their birthday. I give them gifts for Christmas, whatever they celebrate, because I think if you can have staff on your side that you feed and look after, they will back you and prevent problems. So again, I'm sorry to kind of speak, increase your price a little bit to account for that, because it will prevent the heartache later. Every complaint, every medical legal letter, every HCCC is So even a Google review, I think, is very painful because we're all very perfectionistic by nature. Does that answer your question, Doctor?
You have, yeah, indeed. Thank you very much.
Sorry if it was a bit long.
Any other questions? We have a question in the middle there.
This is a question for Dr. Zaidan. Assume like there's a scenario where you're making partial dentures for a patient and their dentition is shade C4. It's very dark, but they want pearly white teeth. How would you bring them down back to earth to let them know that that's not something that's really feasible for them? Should they come back and blame you because it doesn't look aesthetically pleasing?
So every time before we do any treatments, we always have to talk to the patients before we do the treatments. So we need to scientifically explain to them that's not possible. And gray undertones usually don't respond very well to bleaching because of this and this and that. Yellow staining always receive bleaching better. So if you have never done bleaching, don't expect to receive a lot of lightening in the shades. You might get lighter 1 or 2 shades, but it's not going to go very light. And it's up to them to decide whether they go with the treatment or not. It's as long as you explain to them and it's realistic. So you might get 1 shade or 2 shade lighters. You're not going to get all the way down to that shade.
Thank you.
A question here at the front. We'll probably make this the last question.
Thank you so much. Doctor, this question for Dr. Hadi. We medical doctors, we focus on medicine, and anything else for us is a distraction, paperwork, legalities, and what have you, and that's why we get into a lot of trouble. What's your advice if you are say the managing doctor, radiologist, or surgeon, and one of the people, your nurse or my radiographer, did a mistake, injected a patient with contrast without checking if he has allergy or without checking his renal function, what have you. What's your medical legal involvement in that? You are the managing radiologist, but it's not your fault.
You are responsible.
You are responsible.
They call it vicarious liability. So if my nurse does something wrong, I am liable. So the best example in law is if a truck driver crashes into someone and kills them, the owner of the company for the trucks is responsible. Yeah. So you cannot give the responsibility away. What your job then, if this, God forbid, happens, is to ensure that you did everything possible. Because what they'll say is, but I educated them. We have all these protocols. 2 people have to sign. Yeah. In the end, you'll still be liable, but at least it mitigates the risk of your liability. And you could talk about, look, but workers' comp came and I tried this, if it's a workplace injury, or if it's an education issue, at least you've tried. In the end, look, this is my personal opinion. If you have a gut feeling about a staff member that they're sloppy, get rid of them early, because I feel like it's a marker of later subsequent errors. The people who make this mistake usually will make more mistakes. I used to go, oh, it'll be okay, we'll just train them. Now I'm like, you know what, you're out. Because the patients are more important than you. I'm really sorry. So yeah, I sympathize with anybody in that situation, but unfortunately it's our responsibility, both as an owner of the company and as of the doctor on site.
So you still go to court and you still get questioned, although you didn't know about the case at all until it's happened.
If your worker is smoking and they set fire to the building, you are responsible, even though they're not supposed to smoke there. I'm really sorry. This is why in Australia lawyers make a lot of money, because they live off the misery of others.
We better all retire, I think. That's the only solution.
Look, I think medical legal companies are there to protect us, but they protect themselves too, so they just pay it out. So at least we're not personally responsible.
Yeah. Professor Haider, do you think that IAMA and the research committee can arrange for a webinar to guide our undergraduate and junior doctors through the pathway of research in terms of opportunities, in terms of using networking? Do you think we can do that?
Absolutely. There is always a chance for, or an opportunity for the Research and Ethics Committee to prepare certain webinars to focus on different components of the research frameworks. Like we can prepare certain sessions to focus on how to prepare a research proposal, how to write certain research methods based on your research topics, what source of data analysis that you can do. When you've got all the data ready and you've got the paper, where to go next, what source of journals you need to target, and so on. So we can do different kinds of research activities possible.
Thank you very much.
Thank you so much, and thanks a lot again for the great presentation, and what a way to come to the end of this huge successful conference. Thank you again for each and every one of you for coming in, participating, and supporting IAMA. And thank you for the organizing committee of IAMA for putting this day together. It's really been a great pleasure and a big honor for us to be all in here. And each year, IAMA grows and become more and more successful in these conferences. We would like just to make it clear for our following dinner, the gala dinner, it's in this building, but it's not in this room. It's in the ground floor where the ballroom 2, 3, and 4 is. I think it's close to where we took the group photo. So downstairs, and then you move down the hallway all the way to the end and then turn right. Thank you so much again, and thank you.